Okay, so here's a classic board-style question pulled straight from the source text to test your baseline knowledge. Where is the most common site of an accessory spleen? Go ahead and lock your answer in. We'll reveal it in just a few seconds.
Section 1. Anatomy and Function.
All right, if you guessed the splenic hilum, you absolutely nailed it. And surprisingly, accessory spleens are actually found in about 10 to 20% of the population. That's a lot. So when you're in the OR operating, especially for hematologic indications, doing a really thorough search for this extra tissue is absolutely mandatory. If you miss it, the disease is just going to come right back.
Let's quickly break down the histology, because here, form perfectly dictates function. Basically, the spleen has two main functional zones. First, the red pulp. Think of this as your reticuloendothelial system. It calls those old senescent red blood cells and acts as a massive platelet reservoir. Contrast that with the white pulp, which is essentially your immune powerhouse, right? That's where your T cells and B cells hang out. The absolute crucial point to remember for the white pulp is its role in opsonizing pathogens, basically tagging them for immune destruction. And we're specifically talking about encapsulated organisms, which we're definitely going to discuss more later.
Section 2. Indications for splenectomy.
When we map out the major hematologic categories, let's just skip past the myeloproliferative and lymphoproliferative disorders for a second. I want you to focus your attention squarely on the two most common culprits that actually require surgery, the thrombocytopenias and the anemias.
So let's walk step by step through the adult treatment algorithm for idiopathic immune thrombocytopenic purpura, or ITP. This is actually the most common hematologic indication for an elective splenectomy. Okay, step 1. Your first-line therapy is always corticosteroids. Always. But for the 80% of patients who unfortunately relapse after those steroids are tapered, we move to step 2, which is splenectomy or rituximab. The really high-yield takeaway here is that a splenectomy yields a 65% long-term remission rate for these non-responders. That's huge. And if that fails, well, step 3 brings in TPO mimetic agents, things like thrombopoietin, to try to kickstart platelet production.
Now, we absolutely have to contrast ITP with TTP, thrombotic thrombocytopenic purpura. Seriously, do not mix these up on test day. ITP is immune-mediated platelet destruction where the spleen is the main culprit, right? That's why surgery is a standard second-line fix. TTP, on the other hand, is a systemic microangiopathic hemolytic anemia. It's caused by an ADAMS 13 deficiency. So for TTP, your first-line treatment is plasmapheresis, not surgery. A splenectomy is strictly reserved as a last resort for patients who completely fail medical therapy.
Okay, let's fire through the high-yield hemolytic anemias. For hereditary spherocytosis, the buzzwords you need to lock down right now are a defect in the protein spectrin and a positive osmotic fragility test. And splenectomy is actually curative for moderate to severe cases of this. Moving on to autoimmune hemolytic anemia, just remember that warm is IgG-mediated and cold is IgM-mediated. Splenectomy really only plays a role in the warm variant. And finally, sickle cell anemia. This rarely requires surgery, mainly because all those repeated infarctions essentially lead to an autosplenectomy over time anyway.
Shifting gears to non-hematologic indications, drill this fact into your brain right now. Trauma remains the absolute most common reason for a splenectomy overall, and that's guided by AAST grading. Some other notable indications include a splenic artery aneurysm, where you'd intervene if it's 2 centimeters or larger, or if the patient happens to be a female of childbearing age. And finally, splenic abscesses. These are rare but highly lethal, and they're usually seeded from distant sites, think endocarditis or bad urinary tract infections.
Section 3. Preoperative patient preparation.
Listen, there is a strict, completely non-negotiable timeline for vaccinating these patients against encapsulated organisms. These vaccines have to happen either 2 to 3 weeks prior to elective surgery or, in the case of trauma and emergencies, exactly 2 weeks after the procedure. You have to hit this window to guarantee an adequate immune response.
Stop and lock this next point into your memory because it is an absolute golden rule for the operating room, the platelet transfusion rule. You must withhold platelets until the splenic artery is ligated. Seriously, if you transfuse them before ligating that artery, the hyperactive spleen is literally just going to consume those brand new platelets instantly, and you've completely wasted the transfusion.
Section 4. Surgical approaches.
So, laparoscopic is generally our preferred elective approach, but it does have its limits.
Absolute contraindications include massive splenomegaly, which means a spleen greater than 30 centimeters, and portal hypertension. Honestly, at over 30 centimeters, you physically just run out of working space inside the abdomen, and the bleeding risk skyrockets, so you're forced to do an open approach. Relative contraindications, on the other hand, would be moderate splenomegaly, so around 20 to 25 centimeters, or severe uncorrectable cytopenia, meaning dangerously low blood cell counts that you just can't fix beforehand.
Section 5. Post-operative complications. While you're still in the OR, hemorrhage is by far your most common intraoperative hurdle. But think about the regional anatomy for a second. The tail of the pancreas sits right up against the splenic hilum. That close proximity puts the pancreatic tail at major risk for injury during dissection. And if you injure it, that can lead to a post-operative pancreatic leak or isolated hyperamylasemia, which is a really dangerous spike in pancreatic enzymes.
Okay, we have finally arrived at the absolute most critical mortality concept in this entire review, OPI, overwhelming post-splenectomy infection. This is a rare but devastatingly fulminant sepsis. These patients will present with vague, flu-like symptoms that rapidly, and I mean rapidly, progress to bacteremia, consumptive coagulopathy, and death within 12 to 48 hours. The urgency here literally cannot be overstated.
The culprits behind OPC are those encapsulated bacteria that the now absent white pulp used to opsonize and handle for us. Specifically, we're talking about Streptococcus pneumoniae, Haemophilus influenzae type B, and Neisseria meningitis. If you even suspect OPSI, immediate treatment is required. We're talking aggressive supportive care and high-dose third-generation cephalosporins. You do not wait for cultures to result, you act immediately.
Here is a surprisingly common yet really subtle complication. Portal vein thrombosis. It actually occurs in 8 to 12.5% of cases. The tricky part is that symptoms can be as mild as a low-grade fever and some vague abdominal pain, but if you miss it, it can lead to extensive mesenteric thrombosis. Your major risk factors here are massive splenomegaly and myelofibrosis. Because of this, prophylactic thrombolytic therapy is a really major consideration for those specific patients.
All right, let's conclude with one final active recall check straight from the source material. Vaccination of a patient undergoing splenectomy must include which of these? If you answered E, all of the above, you are exactly right. You have to cover that encapsulated trio plus the annual flu shot to prevent any secondary bacterial superinfections. Now, here's a thought to leave you with. We have clearly mastered the art of safely removing the spleen, but considering how devastating OPSI can be, how close is modern medicine to artificially replacing this organ's incredible immune function? Until we can figure that out, mastering these surgical indications and these strict vaccination timelines is quite literally the only way to keep your patients alive. Thanks for joining me on this explainer, and I'll catch you next time.